So I'm going to be speaking about how the molecular mutations are important from the standpoint of someone who does stem cell transplants. And we're going to look at the impact of these on transplant outcomes. So I do have some disclosures to make. I have served as a consultant for Celgene, and I'm going to be discussing off-label uses of sorafenib, azacitidine, quizartinib, and midostaurin. So the outline is that we'll begin talking about the utility of the mutational analysis. I'd like to spend some time talking about difficulties in clinical trial design. As Dr. Bloomfeld said, we need to do a better job of designing our studies, but obviously there are some obstacles that we need to overcome. And then I'd like to end with discussing some future and present studies. So the first question has already been addressed by Dr. Bloomfeld, but I would like to show a different analysis. This is from the Munich Leukemia Laboratories. They looked at 841 patients with AML, and this is a prognostic model based solely on molecular and mutational abnormalities. So they did not include cytogenetics in this model. And they tested 5 molecular alterations and 5 mutations, and you can see the model here from very favorable to very unfavorable. Very unfavorable patients had the TP53 mutations, and then the very favorable had APL, as identified by the PML-RARA, or they had CEBP alpha, double mutated. And as Dr. Bloomfeld pointed out many times, the double mutated CEBP alpha does better than the single mutated CEBP alpha, which is a little bit lower on the list right here in the intermediate risk category. But based purely on a molecular analysis, they were able to divide the patients into these subgroups, which predicted prognosis. Now, Dr. Bloomfeld has pointed out to me that perhaps their information regarding survival and relapse isn't as good as the European Leukemia Net. I initially planned on presenting the European Leukemia Net as Dr. Bloomfeld has mentioned several times, but she's obviously adequately covered that. The point is that mutational abnormalities in AML are here, and we should be using them not only to determine prognosis, but also in using them to determine appropriate therapeutic interventions. MDS, I have to admit, is a little bit far behind in regards to AML therapy. These are 2 publications from the group in Boston, Dr. Ebert's group, that looked at mutational abnormalities in MDS and how they might be incorporated into prognostic models. The first paper identified several mutations in red, which have an overall negative prognostic impact in MDS. And then in green, some mutations that have an overall either no prognostic impact or favorable prognostic impact. And then a later publication looked at incorporating mutational analysis into a prognostic model. That's presented by Dr. Walter. They looked at mutational abnormalities, and they were able to classify patients in worse prognostic groups based on the presence of the EZH2 mutational abnormality. Now, for patients who are undergoing transplant, the mutations can be helpful, obviously, in deciding who should go to transplant. And this is a paper that's been published several years ago now, but basically showing that for patients who are between the ages of 16 to 60 with a normal karyotype and who are NPM1 positive and FLT3 IgD negative, there was no difference in a genetic randomization between donor and no donor. However, in patients who had other genotypes, so NPM1 negative or FLT3 IgD positive, they obviously benefited from receiving a donor transplant in comparison to the no donor group who either got an auto transplant or high-dose ARC. Now, in the donor group, 82% of the patients received an allo transplant, and the treatment-related mortality is 21%. And this is important because in a prior study published in 2005 from the MRC, they actually found no benefit of transplantation in this group of patients. But in their donor group, they only transplanted approximately 63% of their patients. So many of these donors ultimately did not go on to transplant. So this paper might more accurately reflect the positive benefits of transplantation for patients who are FLT3 IgD positive or NPM1 negative. There also has been publications looking at autologous transplantation for patients who are FLT3 positive. And this is the retrospective analysis of the AML96 study from the Deutschland Study Initiative for Leukemia Group. They looked at 555 patients who had intermediate risk cytogenetics who were less than or equal to age of 60. And there were 175 of these patients who were FLT3 IgD positive. And the remission rate for the FLT3 IgG positive was 63%, and then the overall remission rate was 68%. So this is just further evidence that the issue with FLT3 IgG positivity is not getting into remission, but staying in remission. In other words, the FLT3 IgG patients typically have a higher relapse rate. The method of consolidation treatment after patients went into remission was hierarchical, meaning that the preference was for allogeneic transplant if you had a match-related donor. And this was not an intent-to-treat analysis. So all of these patients actually received an allogeneic transplant. So there were 103 patients who received a match-related donor. The second choice of therapy was an autologous transplant. Now, in order to do the autologous transplant, the patients had to undergo GCSF mobilization of their stem cells without relapsing. So there may be a large selection bias here present within the autologous group. And then the default, the third choice, was high-dose Ara-C. And you can see that there was no difference between FLT3 positive and FLT3 negative patients in the allogeneic transplant group in regards to survival. So this is survival. And no difference in regards to auto transplant in regards to survival. But the chemotherapy group obviously had a much lower survival if they were FLT3 positive. They also looked at relapse rates, and the chemotherapy group had a higher rate of relapse with FLT3 positive. The Allo group had a higher rate of relapse if they were FLT3 positive, but the auto group had no difference in relapse rates if they were FLT3 positive. And as I said, I think this probably reflects a selection bias, and that the patients who underwent an autologous transplant had to be successfully mobilized with GCSF without relapsing. There is very limited data looking at alternative donor transplantation for FLT3 IgG positive AML patients. This is a retrospective analysis from Johns Hopkins. In all of their non-M3 AML patients between the ages of 18 and 60 that were consecutively seen. There were 102 patients who were wild type for FLT3 and 31 patients who were FLT3 IgG positive. And again, just to emphasize, this was not just normal cytogenetic AML. These were all comers that were non-APL AML. And they found that there was no difference in survival in their analysis between wild type and FLT3 IgG positive patients. And the argument that they gave is because they're more aggressive in performing stem cell transplantation for those patients who are FLT3 IgG positive. And you can see that they transplanted 60% of the patients who are FLT3 IgG positive and only 17 of the patients who are wild type. Now, on the right-hand side is an analysis of the patients who obtained remission, a complete remission for FLT3 ITD. And there were, as you can see, were 20 of the 31 who obtained a remission. And 11 of these patients received an allogeneic transplant with either a match-related donor, match-unrelated donor, or haplo, and 9 of the patients received no transplant, and you can see that there is a statistically significant difference in survival between these two groups. So just further evidence that transplantation with alternative donors is beneficial for patients who are FLT3 IgG positive. Of course, FLT3 is not the only negative prognostic indicator in AML by mutational analysis, and as presented by Dr. Blumfeld, RUNX1 mutation also has a negative predictive factor. This is a study done from the German-Austrian AML study group that looked at 954 patients with AML between the ages of 18 to 60 years of age. And again, this was all comers, not just the cytogenetically normal patients, but including patients who had cytogenetic abnormalities. 59 of these patients had the RUNX1 mutation. Now, 83% of the RUNX1 mutated patients had normal cytogenetics, so almost all of them had normal cytogenetics, but there were a small percentage of the RUNX1 mutated who had some abnormal cytogenetics. Unlike FLT3 with RUNX1, you find that there is a lower remission rate. So their remission rate was only 60% among the RUNX1 mutated patients, and that was significantly different in comparison to the other groups. Among the 32 patients who obtained a first complete remission, 14 of them received an allo transplant, and you can see here the breakdown between related and unrelated donors. And then 18 of the patients received some other type of therapy, either auto, high-dose Ara-C, or they relapsed or died before going on to some type of consolidative treatment. And there was a statistically significant difference in relapse-free survival between the patients who received an allo transplant and the patients who did not receive an allo transplant, arguing that transplantation is beneficial not only for those patients who are FLT3 IgD positive, NPM1 negative, but also for patients who have the RUNX1 mutation. Mutational analysis can also be used to determine risk of post-transplant relapse. And this is a study, a retrospective analysis that was done by the Acute Leukemia Working Party of the EBMT. And they looked at all AML patients who obtained a first CR with normal cytogenetics over the age of 18. And they looked at patients who were FLT3 IgD negative, which was 86, and patients who were FLT3 IgD positive, 120. And all of these patients received a myeloablative allogeneic transplant. And you can see here the breakdown between related donors and unrelated donors between the two groups. 90 of the FLT3 IgD positive got a related donor, 30 unrelated. 68 of the IgD negative got related donors, and 18 unrelated donors. The patients who were FLT3 IgD positive were 3 times more likely to relapse in comparison to the patients who were FLT3 IgD negative. And then when you looked at the relapse-free survival, the patients who were FLT3 IgG positive only had a 37% chance of remaining alive without relapse in comparison to the patients who were FLT3 IgG negative. So therefore, there is evidence that testing for FLT3 is predictive of relapse in the post-transplant setting. What about MRD monitoring? This could obviously be used in the pre- and post-transplant setting, hopefully at some point in time to develop appropriate therapies for these patients. We have a lot of data regarding the use of flow cytometry to detect minimal residual disease. On the left is a group of MDS patients who were transplanted at the Fred Hutchinson Cancer Research Center, and on the right, a group of AML patients who were transplanted. There were 90 patients with MDS who had a morphologic remission. They underwent a myeloablative transplant with either related or unrelated donors. 59 of these patients had no evidence of minimal residual disease, and 31 did have evidence of minimal residual disease based on flow cytometric analysis. So this was a 10-color multi-parametric flow cytometric analysis. You can see that patients who had MRD positive measured by flow were at higher risk of relapse, and similar data was obtained in patients who had flow positive disease detected in AML group. So basically just demonstrating that flow, of course, can be predictive of relapse. There is emerging data regarding the use of PCR testing for molecular abnormalities to determine risk of relapse. And this is this study from the MRC AML15 trial. This trial was presented by Dr. Applebaum last night, and it showed a benefit effect of gemtuzumab in patients who had favorable risk cytogenetics. But as a subset of this trial, they looked at 115 patients with inversion 16 and measured PCR analysis after obtaining a complete remission. So this time point, 0, is after obtaining complete remission, and they followed them over time. And this analysis looked at peripheral blood. They also did it in marrow. But they basically saw that if you have a positive test by peripheral blood of PCR for the inversion 16 abnormality, you were at higher risk of death. So just indicating that perhaps we could follow patients over time by molecular methods to determine who should and who should not be transplanted. There is data also looking at NPM1 positivity, measuring MRD by PCR. So this again is by the German-Austrian AML study group. They had 245 patients who were NPM1 positive by PCR. Now, this included patients who had normal cytogenetics and abnormal cytogenetics, all between the ages of 16 to 60 years of age. On the left-hand side is after induction chemotherapy, first CR only. So these are all patients who obtained complete remission after first CR. There were 26 patients who had no evidence of minimal residual disease by PCR. So they got into remission. They had testing done on their marrow, and there was no evidence of the NPM1 abnormality. They also looked at the MRD positive patients, which was 111, and they saw that the overall survival was much less in the patients who were MRD positive. And in the patients who were MRD negative, there were 2 upfront deaths from Allo transplant. Now, moving to the right-hand side, this is after completion of all therapy. So they measured not only after first CR, but after patients had completed all of the planned therapy. This was induction chemotherapy for 93, autologous transplant for 11, and allogeneic transplant for 25. So at that time point, they also measured to see whether patients were MRD negative or MRD positive. And you can see that if patients were MRD negative, their overall survival at 4 years was 80%. in comparison to patients who were MRD positive with an overall survival of 44%. So using this data, one could argue that if you have evidence of molecular positive disease in PM1 positive in first CR, that perhaps these patients in yellows are the ones that should be offered an allo transplant, and then the patients in blue probably should not. There's obviously many ways to detect minimal residual disease, and it's unknown now at this point in time which is the best method. And this is one analysis done at the Fred Hutch comparing cytogenetic versus flow cytometry for detecting minimal residual disease in both the pre-transplant and post-transplant setting. It's probably not surprising to us to find that the best group were patients who were cytogenetic negative and flow negative in both settings. But what I found surprising is that it didn't matter if you detected MRD by cytogenetics or by flow or by both. These patients had a worse outcome that was pretty much similar in comparison to the patients who were cytogenetic negative and flow negative. Now, the cytogenetics not only included a standard karyotype, but also FISH. So this is including a FISH analysis as well as standard karyotype. There's also been at least one study that I'm aware of that compared a molecular detection by PCR versus a flow cytometric detection for measuring minimal residual disease. And this is the AMLO2 trial done in pediatric AML. So the AMLO2 trial was actually directed therapy. So they would perform high sensitivity flow cytometry analysis on patients after they developed complete remission, and then on the basis of what that flow cytometry analysis showed, they would plan subsequent therapy. This is a separate study that looked solely at patients who were flow negative. So all of these patients had no evidence of minimal residual disease, in complete remission, and then it's looking to see whether they had molecular evidence of disease or not. And in the yellow, you see patients who had molecular evidence disease who were flow negative. There was only 15. And then in the blue, there were patients without molecular evidence of disease, 48. Now, they screened for all of these molecular abnormalities as listed below, but they didn't see any benefit of molecular minimal residual disease in patients who had no evidence of flow disease. So basically arguing that perhaps at least in this setting, flow cytometry was a better method for determining minimal residual disease than molecular analysis. Now, there are many limitations of this study, and one is that the PCR analysis for these have different levels of sensitivity. So ultimately, I think it remains to be determined whether flow cytometry, molecular PCR, or cytogenetics is the best way to monitor people for minimal residual disease. Finally, I'd like to talk about the therapeutic implications. And this, of course, is exceedingly important when dealing with AML and MDS. Now, this is two curves that looked at survival following post-transplant relapse. And on the left-hand side is a study published in 2003 from the Fred Hutch. All of these patients received a low-dose intensity conditioning regimen, 2-grade TBI, with or without 90 milligrams per meter squared of fludarabine. And you can see that the AML patients and the MDS patients, if they relapsed, had a much worse outcome, more death in comparison to patients with lymphoid malignancies and with CML. So for those of us who are specializing in myeloid malignancies, we haven't done as good of a job in treating patients who have relapsed. And unfortunately, we haven't gotten any better over 9 years, because this is a follow-up study on the right from the EBMT that looked at relapse following a reduced intensity conditioning regimen, and you can see that the survival was very poor. Now, all of these patients were in CR, all of them had AML, and they were in CR at time of transplant and then relapsed. You can see that the survival out to 5 years is exceedingly poor. So, of course, we need to try to improve these methods, these outcomes, but designing clinical trials in order to address this can be quite difficult. And one of these difficulties, of course, is choosing the primary endpoint. Now, it may seem somewhat interesting to say that relapse is subjective, but if you're dealing with a multi-center trial and you have multi-parametric flow cytometry being performed at all of these different centers, and then let's say you're also looking at MRD by PCR, and you have different molecular methods for detecting a minimal residual disease, you can see how at certain centers they might say that a patient has relapsed by MRD, and at other centers they might say that the patient doesn't have any evidence of relapse because they're in a morphologic remission. Overall survival, of course, is more objective. That's easily determined, but it's a longer time point outcome. So the trials have to be followed over a longer period of time in order to determine if you have a benefit in survival or not. Of course, other issues in the setting of transplantation is that it's quite a toxic regimen. And if you're a pharmaceutical company, this is not necessarily where you would want to go to test a new drug, because it can be difficult to ascertain side effects, whether it's due to regimen-related toxicity or graft versus host disease. So this is not meant to be a literal representation of when engraftment occurs or when a robust GVL effect occurs or when one has regimen-related toxicity or acute GVHD. I think Paul Martin would be quite mad at me if I were to give the impression that you can only see chronic GVHD after day 100. But the point here is to say that there is some overlapping toxicities, and because of that, the opportunities for testing new drugs in the myeloablative setting with 4 days of busulfane can be difficult, because it's hard to ascertain whether patients develop the side effects from the treatment or because of acute GVHD. Now, with a reduced intensity conditioning regimen, there might be more of a window to test these new drugs because they're going to have presumably less regimen-related toxicity that would occur earlier, and so there's a little bit more of a green window. And of course, the ideal time to intervene would be at some point between the infusion of the stem cells and the time that a patient develops a robust GVL effect. A next difficulty is determining the appropriate patient population. How do we define who's at a high risk of relapse? Is it that they have MRD before they received a transplant? Is it because they have certain molecular abnormalities? And it's become clear from Dr. Bloomfeld's presentation that we're dealing with individual diseases now. In the age of molecular characterization, there is not a single AML. There's multiple types of AML. And when you start dealing with these individual diseases, it's going to require a cooperative effort, because ultimately there's going to be smaller and smaller number of patients with these specific mutational abnormalities. And when you're dealing with a cooperative effort, there is a balance between the individual and cooperation. And I was discussing this with some of my colleagues, and one of the things that goes underappreciated in the setting of an academic community is how one collaborates with others. Very few people are promoted for being a good collaborator, and that's something that I think is underappreciated in our field. And I think if we were to change that, perhaps we would have better, larger intergroup studies in which we're all able to collaborate and lead to better answers for these patients. A final difficulty is how long do you treat them? Well, you could treat them until the GVL effect occurs, but let's say robust GVL effect, but of course there's a lot of opinions when this would occur. And then there's the questionable of whether or not you would have a benefit with a GVL effect in patients with minimal residual disease, and whether or not you could stop it when the robust GVL effect occurs. Indefinitely, well, if you choose to treat them indefinitely, there's a lot of cost with that, and there's long-term toxicities. All too often, what we choose is, well, when the primary endpoint of the study is reached. And I don't think this is too good of us, because that leaves the people in community practice in a conundrum, because they're dealing in more of a real-world environment. And they can't walk into the patient's room and say, well, the study stopped at 18 months, so now we can stop your study drug, because that's when it was stopped in a clinical trial. So I do think we need to do a better job of determining how long patients would need to be treated, particularly in this setting, for trying to prevent or treat relapse. So there is some studies that have looked at treating patients who are FLT3 IgG positive. These are two separate studies done with sorafenib. On the left-hand side, there were 29 patients who received sorafenib after relapsing. You can see that there was some benefit. On the right-hand side is a study done from MD Anderson Cancer Center with 8 patients who received sorafenib monotherapy, 8 patients who received combination therapy. And you can see that there wasn't much benefit with sorafenib in this setting. This is a study that hasn't been published yet, and I'd like to thank Dr. Pollard for providing me with this data, but they basically showed that there was benefit in disease-free survival for patients who were treated with sorafenib in the post-transplant setting. There are 15 patients overall, 3 prophylactic, 2 who got it for MRD, and 10 who got it because of recurrence after transplant. Quizartinib is a class 3 RTK inhibitor. It selectively inhibits FLT3, and it's currently in phase 1 testing in the setting of transplantation. Many of you may know that the phase 3 trial with that's for midostaurin. But the phase 1 and phase 2 trials have been completed for AC220, and there has been benefit seen in refractory AML patients. So this is just one example of a phase 1 trial with AC220. It's open at 5 different centers, but it's basically treating patients between day 30 and day 60 with AC220, and the primary endpoint is dose-limiting toxicity and maximum tolerated dose. There is in process a phase 3 randomized trial comparing midostaurin in the post-transplant setting. It's not yet completed, of course, but they would take AML patients who are FLT3 IgG positive in CR1, and they would randomize them to either midostaurin or a control group with a primary endpoint of 18-month relapse-free survival. And this protocol is in development, and I think it's very interesting, and I hope that it will quickly accrue and provide us some answers in regards to the benefit of midostaurin in the post-transplant setting. This is a trial looking at azacitidine to treat patients with impending relapse. This is a study being performed in Germany, but it's just yet another example of some of the types of treatments that patients are receiving in the post-transplant setting in an effort to treat impending relapse or frank relapse. And I developed this slide based on my conversations with several of you in the audience, just looking at different trials that are currently in development, AC220, sorafenib, and midostaurin, and then azacitidine, as you see here. And then, of course, I think it would be interesting looking at patients who have APL with KIT mutations who come into transplant, looking at the tyrosine kinase inhibitors. And then there are potential blockers of the RAS-RAF mutations with MEK and mTOR inhibitors. So these are all studies that are either underway or planned in the future. And so, in summary, I'd like to say that the mutational analysis can be used to detect who should proceed to transplant, who is at risk for post-transplant relapse. It's useful for MRD monitoring, and I have the hope that eventually these mutational analysis will be important in determining therapeutic implications, particularly in the transplant setting. And so I would like to thank you for your attention. I'd be happy to take any questions you may have. Thank you. Yes.
I'd just like to make a comment and then hear your opinion. A lot of what's been said, and I'm happy that Clara left because it applies to both of you, but she's probably more violent, or prone towards violence.
I wouldn't be so sure of that.
A lot of this has an element of the emperor's new clothes to me. Let's take the instance of people who are MRD positive doing worse than people that are MRD negative. Well, I mean, before the advent of the microscope, then you now have a microscope. You could look at their bone marrow, and it's just fundamentally the same thing as saying people in whom I can see leukemia cells are going to do worse than people who I don't see leukemia cells. So we're really not talking about this is not a fundamental breakthrough. What's more interesting is that amongst the people that are MRD positive, say after CR, that not all of them relapse. So, John Goldman showed it very nicely last night. For a mutation that we know causes the disease, for BCR-ABL. Yes, if you have BCR-ABL, you're more likely to relapse, but not everyone who's BCR-ABL positive relapses. So that's the first instance. The second instance is the assumption that because we can detect it, we should do something. And, I'm sure you'll agree that what you need to do is to do a randomized trial amongst people who have the event of interest, say MRD positivity, to show that in fact favorably impacts the outcome.
Yeah.
Because otherwise, given the fact that there are false positives, you can wait until they relapse clinically. So we have to prove that early intervention actually alters the course of the disease. And then the third comment is that all of these sort of binary analyses of FLT3 positive and FLT3 negative and whatever group are usually these are completely unadjusted analyses. They're not adjusted for other prognostic variables. So when we look at hazard ratios of 0.3, I mean, in an ordinary circumstance, we wouldn't accept an unadjusted hazard ratio. But here we're looking at curves. Claire has shown a whole bunch of curves where the hazard ratio is unadjusted for every other prognostic variable. other than, say, age or something like that, or cytogenetic group. So I think these are really interesting and important studies, but they have to be taken with a grain of salt and shown in randomized clinical trials before we make a series of important clinical errors in judgment. I don't know if you agree with that or not.
I agree with most everything you said. Yes.
For NPM1 mutation without IDH2, do you recommend transplant or HiDAC?
So I believe you asked if patients are NPM1 positive without
without IDH2 mutation.
Right. So if they're NPM1 positive and they're FLT3 negative, then we would treat them with chemotherapy and not necessarily proceed to transplant. Now, I presented some data looking at MRD after this chemotherapy. So let's say if they were molecularly positive after they got into a complete remission with this chemotherapy, then one could argue that transplant might benefit that group. But I'm not advocating that NPM1 positive, FLT3 negative patients should receive an allotransplant as upfront therapy. I would not say that. Okay, well, thank you everyone. I appreciate your attention. Thank you.